Hatvet PHARMA welcomes you to the ocean of practical knowledge about small animal practice, that is, Hatvet's YouTube channel. We are thankful to Dr. Vinod Kumar for sharing his practical tips with fellow veterinarians.
Hello, my dear friends. Now we are going to deal with diseases of the chest cavity. We know the chest cavity and the whole chest cavity dealing is a Herculean task. It contains lot of organs with lot of different diseases. In human medicine, we have separate branches, like the gastroenterology, which deals with the esophagus running through the mediastinum, pulmonary medicine, which deals with the larynx, trachea, bronchi, lungs and pleura, cardiology, which deals with the heart and blood vessels. So all these are combined in our veterinary practice, and as we all know, we are the cardiologist, we are the chest specialist, we are the pulmonologist, we are the ECG technician, we are the sonologist, and we are everything. And we are the physician, surgeon, and anesthesiologist. So it's a discussion about those diseases of the organs in the chest cavity. So if we are going to discuss about the organs in the chest cavity, it takes a long time. It cannot be included in a single webinar for 1.5 hours. So we divided it into 3 with different topics and different informations. So our session 1 webinar deals with the basics of respiratory medicine. Now in this webinars, we are not going to deal with cardiology, because as you all know, cardiology is an entirely different subject. It has to be dealt with separately. That we are coming. So now we have the chest diseases other than the heart and blood vessels. So our first webinar deals with the basics of respiratory medicine. We know something about the chest cavity. We know a lot. The God has given lot of preferences to his creations. We know the God, he has given the brain. The brain is the master organ of our body which controls everything. So somehow he has to protect the brain to the maximum. So what he did, inside the head, the skull, the brain was kept, and the brain is wrapped with 3 membranes. In between these 3 membranes, he has given cerebrospinal fluid, and everything is dipped in cerebrospinal fluid, all these 3 covers. We should say it is suspended in the cerebrospinal fluid. And then this brain, the whole apparatus is being covered by a bony skull. That too, to avoid impacts from outside, he has kept a two-layered skull. In between, a air-filled bony space is there that we call as sinus. So that much he has protected the brain. That is the most important vital organ. Likewise, we have other vital organs, the heart and the lungs. They are also very important vital organs. He protected the heart and the lungs by keeping it inside a bony cage. We say it is a rib cage. Inside it, he made a thin layer of membrane. We call it as a pleura. With a reflection, he made two membranes. In between, he gave some fluid for lubrication and for absorption of the impact, etc. And inside it, he kept the lungs with rich blood supply. In between the lungs, he kept a space where it is well protected. That is known as the mediastinum. In the mediastinal space, he kept the heart, the major blood vessels, etc. So, the God or the nature was very keen in calculations of how these vital organs are protected. Now, we are going through some anatomical peculiarities of these structures inside the thoracic cavity. As we all know, we have the largest two natural natural body cavities, such as the thoracic cavity, abdominal cavity, and the pelvic cavity. So, in human beings, three distinct cavities are found: thoracic cavity, abdominal cavity, and the pelvic cavity. And humans have the pelvic peritoneum, in which humans are upright standing animals. They stand on the 2 feet. And so the abdominal organs should not descend into the pelvic cavity. And so a reflection which makes the pelvic peritoneum prevents this. This is not needed in the dog or the cat because they are standing as their body long axis is parallel to the ground surface. But our long axis of the vertebral column is perpendicular to the surface of the ground. So we need a pelvic peritoneum. So in the human beings, or we had a distinctive thoracic cavity, abdominal cavity, and pelvic cavity. Our patient, that is a dog and the cat, they have very distinct thoracic cavity and abdominal cavity, and both are being separated by the muscular diaphragm. Even There is no such separation in the birds, we know. There is no diaphragm in the bird. So, anterior to the diaphragm, the cavity we term it as the thoracic cavity. Through the thoracic cavity, certain tubular organs are passing. Like we all know, the caudal vena cava, the esophagus, the aorta, the lymph duct, the vagus nerve, all these being are piercing the diaphragm and passing into the abdominal cavity. So, inside the thoracic cavity, see, in this picture, see, this is only for brushing up. It is not like teaching a third year, a first year student. All doctors who are listening to me are very well popular, excellent, knowledgeable doctors. This is just to brush up our memory. We have our heart and blood vessels. We can see the caudal vena cava, the cranial vena cava, the abdominal aorta, the esophagus, the anterior vessels, etc. And the heart is also positioned well. Here you can see the right side of the heart. The right atrium can be seen here. The right ventricle can be seen here. A little bit part of left ventricle also can be seen here. So this is the floor is produced by the sternum, and the roof is being produced by the thoracic vertebrae. So these are some of the anatomical considerations. And we have the trachea. And the trachea we have two parts. The esophagus also we have two parts. The trachea we have the extrathoracic trachea, that is a cervical trachea, and the intrathoracic trachea or the mediastinal trachea. So as the esophagus also has the thoracic esophagus and the cervical esophagus found on the neck. The esophagus and trachea are moving caudally through the mediastinum. So all these things, these organs will pierce the diaphragm and which passes into the abdominal cavity. This piercing hole is known as the hiatus. When the esophagus is piercing the diaphragm through a hole, we say the hiatus esophagus. When the aorta is piercing, we say the hiatus aorticus. So we have these organs inside the thoracic cavity. This picture is just an illustration to show the cut off on right side of the thoracic cavity. Coming to the left side of the thoracic cavity, here you can see these are all schematic representations. You can see the cranial vena cava. See, in human beings, there is no cranial vena cava and caudal vena cava. In human beings, we are standing only straight, perpendicular to the surface of the ground. So, in human beings, the terminology is different. We say as the superior vena cava and the inferior vena cava. So, this is the superior vena cava or the cranial vena cava. Here you can see the left ventricle, a part of the right ventricle. The left atrium can be seen here. The aortic arch can be seen here. The thoracic aorta passing through, touching the diaphragm, piercing the diaphragm through the hiatus aorticus. You can see the esophagus here, piercing the diaphragm through the hiatus esophagus. One lobe of the lung can be seen here, and in some animals you can see the intact or the rudimentary thymus gland situated in the anterior floor of the thoracic cavity, close to the thoracic inlet, lying on the sternal floor. And here you can see the nerve plexuses arising from the thoracic intervertebral space, forming the brachial plexus, and the phrenic nerve, the vagus nerve, everything can be seen here.
Hatvet PHARMA presents PantoHat, proton pump inhibitor systemic drug, a powerful tool to prevent and treat gastric ulcers and esophagitis. PantoHat IV injection, pantoprazole 40 mg vial. Indications: to prevent and treat gastric ulcers and esophagitis. Dosage for dogs and cats: 0.7 mg to 1 mg per kg over 15 minutes once daily. Route IV. Presentation: 40 mg vial. Pantoprazole sodium tablets, PantoHat 40 tablets. Pantoprazole 40 mg. Indications: to prevent and treat gastric ulcers and esophagitis. Dosage for dogs and cats: 1 mg per kg per day. Route oral. Presentation: 1 into 10 tablets. You can book your order online at www.hatvet.com. Looking forward to a long-lasting business association. Thank you.
So, this is simply the anatomical consideration of the chest of the dog. Upon a schematic representation, we have to study something about the mediastinum and the pleural space. For that, only an illustration is needed. Otherwise, when we dissect and see, or from photography, sometimes a junior may not be able to understand it well. So, as I said, the God has given the pleural membranes, right? The pleural membrane is here. The pleura, two layers are there in the pleura, and I will show you another illustration. This is the next illustration. Here you can see very well. See, this is the cross section of the thorax. This is the body of the thoracic vertebra, dorsal process, and here you can see this is the pleura. Here you can see the pleura. See, the pleura is closely adhering to the thoracic wall, adhering to the thoracic wall, and then at the sternal area it is going and then again reflecting here. It is reflecting here. See, it is reflecting. It is then covering the lungs. Covering the lungs. See, this is the lung. So in between, this is one layer, and this is the visceral layer, and the pulmonary layer, and this is a thoracic layer. So in between these two layers, you can see the space. So the space is formed here. The space is entirely seen here. This is a space. This is known as a pleural space. In the pleural space, there is a fluid which is given. There is a pleural fluid for lubrication. And here you can see when it is reflected, encircling the lung, completely encircling the lung, and then coming here, and this area it is again reflecting as the parietal pleura. As thus, one hemithorax is completed. And you can see the gap here. So we say that the mediastinum is incomplete. So also on the other side, the other hemithorax. This is the right hemithorax, left hemithorax. In between you can see the space. This space is known as the mediastinum. This is the mediastinal space. I think anybody who would not have understood might have understood by this time. So mediastinum, the lungs, the visceral pleura, the parietal pleura, the pleural space, etc. Here also you can see the same. See, the thoracic pleura, its reflections over the diaphragm, its reflections over the mediastinum, its reflection over the lung, reflection over the lung, it is covering the lung, and between you can see the pleural space. See the pleural space, and you can see the mediastinum. In the mediastinum you can see the heart. So the pleural space, everything can be seen as illustration. This is another picture just to show the illustration. See the incomplete mediastinal reflections, the visceral pleura, illustration. See in this illustration also, it is a little bit more deep. This is from the left side. You can see all the ribs, the first, second, third, fourth rib, etc. All those ribs, the intercostal space. In between you can see the thymus, you can see the heart, you can see the caudal vena cava, you can see the aorta, the aortic arch, the subclavian artery, the extrathoracic artery, the intrathoracic artery, the carotid artery, then the anterior vena cava, the pulmonary artery, the esophagus. Everything can be seen here. The lungs, and the diaphragm also can be seen here. This is from the left side. and the rib cage from the right side. Also here also you can see the esophagus, the posterior vena cava, the trachea, the heart, the lungs, the thymus, the various arteries. Everything can be seen here. So that was just for refreshing our anatomical knowledge in the chest cavity. Now, coming to the lung of the dog. We all know that the heart, the apex of the heart is slightly tilted to the left. And so, the left has less number of lobes of the lung than the right lung. The right lung has 4 lobes, whereas the left lung has only 2 lobes. This and this together makes the cranial lobe of the lung, and this is the caudal lobe of the lung. So this is the left side, this is the cranial lobe of the left lung, caudal lobe of the left lung. See, the cranial lobe of the left lung has 2 separate lobulations. The anterior part, that is the cranial part, and the posterior part, that is the caudal part. So we should say that there is cranial part of the cranial lobe and caudal part of the cranial lobe, and then the next lobe is caudal lobe. So this is caudal part of the cranial lobe, and this is the caudal lobe. And on the right side we have the 4 lobes, distinct 4 lobes: the cranial lobe, the middle lobe, the caudal lobe, and the accessory lobe. Accessory lobe is slightly coming to the, pushing the lungs and the heart to the left side, and thereby if we take a radiograph, lateral chest radiograph, we can see the tilting of the mediastinal membranes backwards and downwards. And when you take the VD or the DV radiograph, we can see tilting of the caudal mediastinal membranes towards the left side. This is only due to the pushing of this accessory lobe. Okay, so these are the lobes of the lung, or the anatomical feature of the lung of the dog. We have 4 lobes on the right side and 2 lobes on the left side. And the cranial lobe of the left lung is again lobulated into cranial part and the caudal part. Okay. Again, I am simply showing the left lung. See, the left lung, we have 2 lobes, the cranial lobe and the caudal lobe. The cranial lobe clearly shows 2 distinct lobulations. The cranial lobe of the cranial lobe, cranial part of the cranial lobe, the caudal part of the cranial lobe, then the caudal lobe. Coming to the right lung, you can see 4 distinct lobes: the cranial lobe, the middle lobe, the caudal lobe, and the accessory lobe. This is the visceral surface of those lobes. So you can see the right lung, the cranial lobe, the cranial part of the caudal lobe, caudal part of the caudal lobe. So sorry, the cranial part. This is the cranial part of the cranial lobe, the caudal part of the cranial lobe, and then is the caudal lobe. Okay. Coming to the right one, we have the cranial lobe, we have the caudal lobe, there's accessory lobe, all these things are middle lobe, etc. All these things are there. When you look the lung of the, see, we have to study these lungs, because while going through the radiographs, if it is a clear radiograph, some of these lung lobes are distinctive, so that we can say which lobe is affected to a certain extent. I am not a good radiographic specialist or a radiology specialist, but between us there are a lot of radiology specialists. We can ask them if it is clear radiograph. The radiologist will clearly say that there is severe edema of the right lobe, or there is severe edema of the left lobe, left cranial lobe, the left cranial part of the caudal lobe. Like that they can say. And in the feline lung, the anatomy of the cat lung is just simply similar to that of the canine lung. So the cat lung is similar to the dog's lung. They have the same thing. The left lung has two distinctive lobes, and the one lobe is divided, the anterior lobe. The cranial lobe is again divided or lobulated into two, the cranial part and the caudal part, and a very distinct caudal lobe. Like in the dog, in the right lung we have the anterior lobe, that is apical lobe, then the cardiac lobe, diaphragmatic lobe and accessory lobe. 4 lobes are there. Only the name is different. Okay. The cut open lung. You can see the lung which is cut open before inflation. It is deflated, soft, sponge-like parenchymatous tissue. On deflation, it gets filled with air. On inflation. Okay. So, while we inspire, the air is moving into the lungs. So the total amount of air moving in and out of the lung during a breath, it is known as the tidal volume. How much of volume has gone inside and how much has gone outside? Total makes the tidal volume. So, tidal volume is very important to determine the lung capacity. Sometimes due to alveolar pulmonary edema, there will be reduced lung capacity, so that the tidal volume itself will be decreased. So the tidal volume is always related to the total lung capacity. How much of air can enter the pulmonary alveoli? Then another technical term is minute volume. Minute volume means how much of air is being inhaled and expelled during a minute. That means the breathing frequency or the breath per minute, RPM, the respirations per minute, is multiplied with the tidal volume. That gives the minute volume. In pulmonary medicine, minute volume is very important. In chronic pulmonary edema or in pulmonary fibrosis, the minute volume is reduced. But all these are applicable. Exact calculation of minute volume, etc., are mostly applicable in human beings, not in dogs. So, by dividing a breath into its component, inspiratory and expiratory phases, each phase can be characterized by changes in 3 parameters: volume, airflow, and pressure. These are the attributes which we keep in mind while dealing with pulmonary diseases or going deep into pulmonology. Just keep in mind, that is all. We have to study deep into the breath sounds because our major diagnosis depends upon a thorough auscultation. So we have to study from where the breath sounds occur. Breath sounds can be normal or abnormal. The normal breath sounds mostly can be heard. We have auscultation. Auscultation is a process of listening to the sounds from inside the body. So chest auscultation, lung auscultation, pulmonary auscultation. Pulmonary auscultation strictly means auscultation of the lungs. So while you are auscultating, you are listening to the sound produced from the lungs. How sound is being produced? If you are auscultating a dead body, will there be any sound? No, nothing at all.
Hatvet PHARMA presents Rajdox injection, suspension and tablets. The safe option of antibiotic to breed-resistant infections. Rajdox injection, doxycycline hydrochloride 100 mg vial. Route IV. Presentation 100 mg vial. Rajdox oral suspension, doxycycline monohydrate 50 mg per 5 ml. Route oral. Presentation 60 ml. Rajdox LB 100 tablets. Doxycycline hyclate 100 mg plus lactobacillus 60 million spores. Rajdox LB 200 tablets. Doxycycline hyclate 200 mg plus lactobacillus 60 million spores. Rajdox LB 300 tablets. Doxycycline hyclate 300 mg plus lactobacillus 60 million spores. Indications: leptospirosis, ehrlichiosis, anaplasmosis, Lyme and bacterial infections. Dosage for dogs: 5 to 10 mg per kg twice a day. For cats, 10 mg per kg once a day. Route oral. Presentation 1 into 10 tablets. You can book your order online at www.hatvet.com. Looking forward to a long-lasting business association. Thank you.
Why? Because there is no air movement. So sounds can be heard only when air is being moving in and out of the upper and lower respiratory tracts. That means while inspiration and expiration. Okay, so first of all we are going to talk about the normal lung sounds. See, I already said that lung sounds will occur only when air is moving through the airways. The airways can be the upper airway or the lower airway. The upper airway means from the nostrils, the tip of the nose to the up to the level of the tracheal bifurcation. That much is the upper airway tract. Lower airway tract means from the tracheal bifurcation, from the point of that means the tracheal carina. From the point of tracheal bifurcation to the alveolar borders. Okay, that is the lower respiratory tract. We commonly put abbreviations like IRT and LRT. IRTI, sorry, URT and LRT. URTI means upper respiratory tract infection. LRTI, lower respiratory tract infection. So, when you auscultate each and every part of the lung, you need to auscultate the upper airway tract as well as the lower airway tract. When you are auscultating the upper airway tract, it is better you keep the stethoscopes, the bell or the diaphragm on the thoracic inlet, and then carefully listen to it. You can hear the sounds of the trachea up to the bifurcation, so that your auscultation of the upper airway tract will be completed. So on auscultation of the lower airway tract, you have to auscultate the chest wall. When air is being moving through the bronchus after bifurcation, that means the air has entered the lower airway tract. Through the bronchus differentially divides into 4. The dorsal branches, the ventral branches, the medial branches and the lateral branches. These are the 4 branching system of the each bronchi. So the bronchus divides into so many bronchioles, like as the tree branches. So we term it as a bronchial tree. Okay, that's a bronchial tree and bronchus. So air is passing through the bronchus, then passing through the bronchioles, and after at the end of the bronchioles, it reaches the bunch-like alveolus. Normally, the alveolus will be deflated. As when the air reaches there, it will become inflated. So air enters and fills up the alveolus. Here, this inspired air comes into contact with the mucous membrane of the or the epithelium of the alveolar surface. There we have the capillary blood vessels through which waste products or waste gases such as carbon dioxide, ammonia, etc. can be transferred to the inspired air, and oxygen in the inspired air can be transferred to the hemoglobin by a process known as diffusion. Exchange. So again, after complete exchange, the oxygen will be transferred, the carbon dioxide, ammonia, methane, etc. will be received from the capillary blood. It has to go out. So a passive respiration, a passive expiration occurs. So inspiration is active and expiration is simply passive. There is no much effort needed for expiration. So by expiration, all these unwanted gases will be liberated or excreted from the pulmonary alveoli. So during this time, when it is going and coming out, especially when it is going out, going inside, it will be in a little bit high pressure than what is going out, because inspiration is active. Okay, and so it will be going in, and while it is going in, it will rub through the surface, the mucosal surfaces. And according to the nature of the mucosal surface, this rub will produce a friction, and this friction sound will be transferred to the pulmonary parenchyma, and this pulmonary parenchyma will transfer this vibration, the friction vibration, to the chest wall. When you keep the diaphragm of the stethoscope on the patient's chest wall, you will hear this vibration, and then from this vibration you will have to find out what has happened inside, so that we should have a thorough knowledge of what is where. This is the area of the left bronchus, this is the area of the right bronchus, this is the area of the cranial lobe of the right side, this is the area of the cranial lobe of the left side, this is the area of the intermediate lobe of the right side, this is the area of the caudal lobe of the right side, this is the area of the accessory lobe of the right side, etc. Like that, we will have to be thorough of the anatomical knowledge. This is the area of the tracheal bifurcation. These are the areas of the alveolus, etc. So, according to these areas, the sounds originate will also vary. The sound will not be similar to the sound which is passing through when the air is passing through the larynx. If it is passing through the trachea, it will not be similar to that of the air passing through the larynx. When it is passing through the trachea, it will not be similar to those while it is passing through the bronchus. It will not be similar to the air passing through the bronchioles, and it will not be similar to when it is passing into the alveolus. So all this sound will differ. So how we can differentiate the different sounds, different normal sounds? These different normal sounds can be differentiated by auscultating different normal animals. That is why to my internship trainees and to all of my junior doctors, I always say, go on auscultating the animal, each and every animal presented to the clinic. Auscultate each and every part, the lungs, the trachea, the mediastinal areas, the thoracic inlet, the bronchus, the bronchioles, the alveolars, the apical areas, the peripheral areas. So auscultate everything. When you go on auscultating, only after 10 or 15,000 auscultations, we will come to know thoroughly about the normal lung sounds. See, abnormal lung sounds can be appreciated only after thoroughly knowing the normal lung sounds. We have a lot of constraints. Like, it is not just like human beings. Human beings, they do not have a haircut like the dog has. If it's a bush-coated German Shepherd, auscultation becomes sometimes very difficult because it is double coated with fur. Sometimes we may miss some findings, but that is not the case of human beings. Human beings, we have a bare chest, and our hairs on our chest is not sufficient enough to mask the sounds during auscultation. So that is what is happening in auscultation. But when you auscultate during the first times, the diaphragm of the stethoscope may be rubbing through the fur. And the hair rub can be heard while you are auscultating. As when time goes on, you will automatically come to know how to mask this. Then after some years, you will not be hearing this hair rub at all. That is what people like me can have, because we seniors have been already auscultating lot of animals, and we will automatically overcome this hair rub. So the breath sounds. Breath sounds are of three types. Normal breath sounds, the bronchial sounds, the bronchovesicular sounds, and the vesicular sounds. So the bronchial sounds, bronchovesicular sounds, and the vesicular sounds. See, all these breath sounds are being produced mainly during inspiration. So inspiratory breath sound is much more important than the insignificant expiratory breath sound. Of course, that also we can study. So now we have three main normal breath sounds, like the bronchial sounds, bronchovesicular, and the vesicular sounds. Let us see what a bronchial sound is. As the name indicates, the bronchial sound means the sound obtained when air is being passed through the bronchial lumen. So as I said, the air will be rubbing onto the inner mucosal layer and producing these vibrations. Imagine if there is a pathological issue in that mucosa, like a bronchitis. During a bronchitis, there will be exudates. So it will be vibrating onto the uneven surface. The sounds obtained when air is being passed through a wet tube produces the bronchial sound. So in a normal sound, normal animal, you can hear the bronchial sound, which consists of a full inspiratory and expiratory phase, with the inspiratory phase usually louder than the expiratory phase. That is why we consider the inspiratory phase more important. See, these are normally heard over the trachea and larynx. These are the bronchial sounds which can be heard over the trachea and the larynx. Bronchial sounds are not normally heard over thorax in resting animals. See, in resting animals, the respiratory air pressure inside the air column will be very low, because respiration will be so shallow and it is in a relaxed mood also. But in an animal which is excited, animal with fear, animal with severe acidosis, animal with pulmonary pathologies, etc., there will be increased rate and depth of respiration.
Hatvet PHARMA presents Clindahat range, Clindahat syrup and tablets, lincosamide antibiotic systemic drug, a weapon to fight deadly infection with care. Clindahat tablets, clindamycin 250 mg tablets, clindamycin 600 mg tablets, Clindahat syrup, clindamycin 25 mg per ml. Indications: skin infections, dental, osteomyelitis, and protozoal infections including toxoplasmosis. Dosage for dogs: 5.5 mg to 33 mg per kg every 12 hours. For cats, 11 mg to 33 mg per kg once a day. Route: oral. Presentation: 1 into 10 tablets, 60 ml. You can book your order online at www.hatvet.com. Looking forward to a long-lasting business association. Thank you.
And when the rate and depth increases, definitely the air pressure inside the airways also increases, so that the bronchial sounds can be audible loudly. Especially when it becomes frightened, there will be tachypnea. Sometimes there will be panting and tachypnea. See, it happens during when it gets excited or get frightened because of the hormone adrenaline produced, which is a flight, fight, fright hormone. Flight, fright, fight hormone. So, in this time you are going to auscultate, means bronchial sounds could be clearly auscultated. Otherwise, if in a normal animal, if you hear a large or a loud bronchial sound, it shows that there is a chronic lung pathology, such as a pulmonary consolidation. So that is a bronchial sound, or we can say a bronchial murmur. Then we have to study about the bronchovesicular murmur or the bronchovesicular sound. Again, this is more loud during inspiratory phase. It consists of a full inspiratory phase with a shortened and softer expiratory phase. So it will be generally much silent, and the pitch will be much more increased with softer sounds during inspiration. So that is a bronchovesicular murmur. Don't think about the bronchovesicular murmur. Mostly it cannot be heard in a non-excited animal. That is a bronchovesicular normal bronchovesicular sound or bronchovesicular murmur. Here also, as in the bronchial murmur, if the intensity is more, which is found in a resting animal, you can say that there is a chronic consolidative pulmonary pathology, like pulmonary consolidation. That's a bronchovesicular sound. Then comes the last one, the vesicular sounds. As when we auscultated the bronchial sounds, the bronchovesicular sounds, etc., we auscultated the areas of the trachea and the bronchus to hear or to listen to the bronchial sounds and vesicular sounds. Bronchial sounds and bronchovesicular sounds. Now, coming to the vesicular sound means now the air has entered the alveolus. Alveolus is only in the terminal areas. You need not auscultate the trachea and the bronchus. There you cannot see the alveolus. So to auscultate the alveolus, we have to go to the lung periphery. Auscultate the lung periphery. So vesicular breath sounds consists of a quiet, wispy inspiratory phase followed by a short, silent expiratory phase. Vesicular sounds are very, very difficult to find. I frankly say, I cannot simply determine or simply auscultate and hear the vesicular sounds of a normal dog. If at all there is loud vesicular sounds in a normal dog, there should be fibrinous exudates inside the alveolus as a sequel to a pulmonary consolidation. So they are generally heard over the periphery of the lung field. See, strictly speaking, the vesicular sounds are actually not produced by the air moving through the terminal bronchioles. Now, in a vesicular sound, to produce means it has entered the alveolus. From the alveolus, there is no movement. Moving through the terminal bronchioles and alveoli, but rather as a result of attenuation of breath sounds produced in the bronchi and the hilar region of the lung. You simply keep in mind that vesicular sounds are produced when it is entering the alveolus from the bronchioles. And generally, you cannot hear any vesicular sounds. In some textbooks, it is said that carefully auscultate you can hear. No, you cannot hear any vesicular sound in a normal animal, especially resting animal. Sometimes in highly excited animals, you may be able to hear it. Here also, if it is an increased intensity of the vesicular sound, almost 99% it is sure there is a pulmonary consolidation. So, after auscultating through a minimum of 15,000 normal dogs, you will be able to determine abnormal sounds on auscultation of the lung. So there are certain abnormal breath sounds. Number one, abnormal lung sound is crackles. Crackles occur as when you are crushing a plastic paper. It occurs when the air abruptly enters the alveolus, but the alveolus has exudates on the lining epithelium and they were sticking together. Air is entering and the sticking will be released and it is accommodating the air and the air is rubbing this alveolar mucous membrane which is coated with this exudate. So that is crackle. If there is too much of exudates, you can hear a coarse crackle. If there is little bit of exudates, you can hear a fine crackle. Crackles are very common in bronchopneumonia. Bronchopneumonia is very common, like when there is aspiration pneumonia or when there is pneumonia sequel to canine distemper. You can see this bronchopneumonia. In bronchopneumonia, crackles will be heard. So crackles are fine and coarse crackles. So they will be discontinuous, explosive type, popping sounds that originate within the airways. So they are heard when obstructed airway suddenly opens and the pressure on either side of the obstruction suddenly equilibrates, resulting in transient, distinct vibrations of the airway wall. I think now we have got clear. Here also, crackles are mostly heard very commonly during inspiration, because while inspiration it is the air is being pushed into, or the air is rapidly being filling into the alveolus, so that the stick together alveolus will be wide opening. These crackles can be said. So when one alveolus is opening, a tick sound will be heard. See, imagine thousands of alveolus opening in just microseconds fraction time. Click, 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 click. This voice will occur. This is crackles. So crackles show exudative pneumonia. Then second abnormal heart and lung sound is wheezing sound. This is a wheezing sound. Wheezing sound. Because while air is being entering into the trachea, okay. But air will entering from the trachea into the bronchus and to the tiny bronchioles. And these tiny bronchioles sometimes will be narrowed due to spasms, or sometimes the mucosa of the bronchioles will become so thick and edematous due to the inflammation inside. So we know our musical instruments, like the musical instrument can be kept on our lips and we forcefully blow into it. So a P sound will occur. Why it occurs? It occurs due to that we are narrowing the head of that instrument. And while forceful blowing is done into that narrowed area, a heavy vibration occurs in that area, and this vibration is heard outside as a musical sound. The same thing occurs here in the bronchioles. A musical sound is occurring due to the narrowing of the bronchioles. This musical sound is known as wheeze. Very commonly we can hear this wheeze in asthma in human beings. When they inspire, this sound can be heard. It's a wheezing. Mostly wheezes to a certain extent can be heard without auscultation. So, as when air is passing through a collapsed airway, and as when it forcefully it is going inside, it is opening and gradually closes during expiration. This musical sound is produced. Wheezes can be classified as either high-pitched wheezes or low-pitched wheezes. High-pitched wheezes means this is high-pitched wheezes. Low-pitch means these are low-pitched wheezes. So different pitches So high pitch and low pitch occurs due to the extent of or owing to the extent of bronchoconstriction. When it's constricted too much, and sometimes the walls will be sticking together. As when the air is coming, it will be relaxed. In this condition, but not too much of relaxation. So air will be moving as if it is pressing, it is compressed. So air takes too much of pressure to go inside. In such conditions, there will be high pitched wheezes. If it is not that too much, low pitched wheezes.
Hatvet PHARMA introduces Hatcot DS, penicillin sodium phosphate 10 mg per 5 ml oral solution. The ultimate power of steroid with double strength. Penicillin sodium phosphate oral solution, Hatcot DS syrup. Glucocorticoid systemic drug. Indications: anti-inflammatory and immunosuppressive. Dosage for dogs: 0.5 mg to 1 mg per kg per day. For cats, 1 to 2 mg per kg per day. Route: oral. Presentation: 60 ml. You can book your order online at www.hatvet.com. Looking forward to a long-lasting business association. Thank you.
So when it is high pitched wheezes, it shows the severity of the infection. So it is written here, wheezes are significant as they imply decreased airway lumen diameter either due to thickening of reactive airway walls or collapse of airway due to pressure from surrounding pulmonary disease. The same thing was that why explained. Then striders. Striders and sterters. Striders are occurring. See, this wheezes occurred due to narrowing of the lower airway tracts. But striders and sterters arise from narrowing of the upper airway tracts, especially the laryngeal areas and the trachea. Striders means when this is too much narrowed, a low pitched musical sound arises. So striders are intense, continuous, monophonic wheezes, musical sounds heard loudest over the extrathoracic airways. These are the cervical trachea. They tend to be accentuated during inspiration when extrathoracic airways collapse due to lower internal lumen pressure. So striders are commonly heard during inspiration and it will be exacerbated during inspiration. See, even striders and sterters, these are both respiratory noises which can be heard without auscultation. It is audible from outside. Striders, it will be heard as like that, a musical sound. So it will be high pitched. So stridor is significant and indicates upper airway obstruction. But whereas in sterters are very noisy, very large, voluminous voices, are poorly defined and inconsistently used term to describe harsh, discontinuous crackling sounds heard over the larynx or the trachea. Stertor will not have a musical quality, just like a purring voice. like that it will be. Stertor will not be having a musical quality, but striders will be having a musical quality. And if you hear a stertor which is of low pitch, it will be very louder. You should immediately think that too much of excretions and secretions are there, or there is a laryngeal paralysis. There is a stertor. Sometimes we can say it occurs as a snoring, a very loud snoring voice. How will you clinically evaluate a subjected respiratory disease? There are certain clues which we will get by clinical examination or anamnesis. For example, if a pug or a French bulldog or a boxer or a bulldog is presented to you with severe respiratory distress, like this severe respiratory distress, especially this is very common in pugs, the severe respiratory disease, distress, and you can see cyanotic gums, cyanotic tongue, a blue tongue. That itself is conclusive that it is a brachycephalic airway disease. Brachycephalic airway syndrome is very commonly found in our clinics. Can be due to stenotic nares. It is very commonly found in pugs. It could be due to elongated soft palate. It could be due to everted laryngeal saccules. So this is very commonly found. And this is a very common case where our intelligent surgeons make some money. Because after surgical treatment, immediate relief will be there to such patients. Either we can cut a triangular portion of the lateral nares, or the LR nasi, so that almost 30 to 40% of the problem will be reduced. Because there is stenotic nares. The main problem is with the LR nasi. Or we can open up and do a dramatic surgery by excising the excess hanging down soft palate. It is not so simple. It's a major surgery, bleeding can occur, and sometimes if you are not intubating and doing it, blood may even flow into the trachea, producing asphyxia. So those are things which generally ordinary surgeons cannot do, but those surgeons who have that much of setup, like positive pressure ventilator, safe anesthetic procedures, etc. So that is an upper airway obstruction, which is known as brachycephalic airway syndrome. Then other clue, cardiogenic pulmonary edema is a common cause of respiratory disease in small breed dogs with chronic valvular disease. Yes, we all know the right-sided heart failure, which is sufficient enough to produce ascites, and a left-sided heart failure is sufficient enough to produce pulmonary edema, cough and respiratory distress. And left-sided heart failure is mostly associated with mitral valve diseases. And certain other clues, like a cat is presented to you with cough. If a cat is coughing, 99% it will be feline asthma. But a dog is coughing means it could be bronchitis, or tracheobronchitis, etc., or pulmonary disease. which we will have to diagnose. Then take the history. Sometimes the cat may be presented after a motor accident, like the car has hit and went away. After that, respiratory distress happens. The diaphragm of the cat is so flimsy, it can break up, and the abdominal contents like the intestines, etc., can herniate into the thoracic cavity through a diaphragmatic fissure or a rupture that can produce severe respiratory distress. Pulmonary contusion after motor accident. Pneumothorax. I have seen pneumothorax formed after attack of porcupine in 3-4 dogs, hunting dogs. Porcupines are abundant in Kerala state. Hunting dogs will go near it and they will try to grab it with their mouth. For the first 15 minutes, porcupine will try to escape only. They won't attack. But when they come to know that they are going to be, or their life is in danger, they will shake their body so that all the thorns, very sharp thorns are there. Thorns will be spurted onto the body of the predator, and it may even go into the eye, producing serious injuries to the predator. And it can even pierce the thoracic wall, and these people, what they do is, they will get the dog and they will release it, simply release it, but the pierce, this hole will be there for a microsecond. Through this hole, air will enter and it will start severe gasping. It will be presented to the hospital. When we take the radiograph, there will be pneumothorax. I said this should be released only after having a positive pressure ventilation. But the people, they will release it only when the respiratory distress is there. They will be presenting the dog to the clinic. So also in flail chest, that also occur in motor accidents. Flail chest means injury of the thoracic wall, and there is multiple fracture of 2 or 3 ribs. Sometimes when the rib is fracturing, the sharp piece of the rib can turn inside. It may pierce the lung, producing severe pulmonary injuries. If such a lung is being ruptured, air can escape out. You can see that the lung will be bulging out during every expiration. During every expiration. During inspiration, the chest wall will be expanded, but this area of trauma will be pulled inside. During expiration, the chest wall will be deflated, but the area of the trauma will be exflated, bulging out. So this condition is known as a flail chest. I will show you the video. Then, history of cough in a cat. It is an international truth that if the cat is having cough, it will be asthma. Go on with asthma therapy. Go on with a bronchodilator or a corticosteroid. But if a dog is coughing, it means it could be a tracheobronchial disease or interstitial lung disease or pulmonary edema. How will you physically examine a dog with a pulmonary disease or a respiratory disease? The initial observation can be done with observation. Don't touch it. Simply go to the pattern of respiration. can be a Biot's respiration, can be a Heinz-Strock respiration or a Kussmaul respiration. All these are very dangerous respiration patterns. Or a normal thoraco-abdominal respiration, or an abdominal respiration only. Thoracic wall is painful, like in the waves of pleurisy. Then the main examination is listening to the sounds produced inside the thoracic cavity. That is auscultation. Go for the presence of abnormal lung sounds such as crackles, wheezes, rhonchi or rails. We have dry rails and moist rails when there is exudates inside the lower airways. Then crepitus, when there is emphysema, rupture of the alveolus, there will be crepitations. All these are associated with the lower airway and pulmonary parenchymal diseases. When there is much reduced lung sounds or no lung sounds could be auscultated at all, that means there is some barrier in between. Something is obstructing the lung and the diaphragm of the stethoscope. What is it? A water-filled field. That is nothing but the pleural water. That is a pleural effusion. It's a pleural space disease. So in pleural space disease or pleural effusion, we cannot auscultate any sound from inside. All the sound will be absorbed by the pleural water, pleural transudate. Then auscultation of the heart. It is not our area, but simply to study cardiac auscultation should be done. A murmur in the heart, gallop or other arrhythmia may indicate underlying cardiac disease. See, cardiac diseases and lung disease are closely associated. So study of cardiac diseases is very important when studying pulmonology. So a murmur, gallop or other arrhythmia may indicate, what is the gallop rhythm? Normally there will be only S1 and S2, lub and dub only. If it is more than lalab dub dub, lalab dub dub, there means it's a gallop rhythm. More than two lung sound or heart sounds, it's a gallop rhythm. Lalab dub dub dub, lalab dub dub dub, it is a gallop rhythm. That means like a horse galloping. Murmur, gallop or other arrhythmia may indicate underlying cardiac diseases, and the potential for cardiogenic pulmonary edema or pleural effusion should be ruled out. So, in general, breathing pattern helps narrowing of the list of differential diagnosis. For example, upper airway obstruction is associated with inspiratory dyspnea. Whenever you see, there are two types of dyspnea. Three types of dyspnea are there. Number one is inspiratory dyspnea. Number two is expiratory dyspnea. Number three is restrictive dyspnea. Inspiratory dyspnea means difficulty in inspiration. Expiratory dyspnea means difficulty in expiration. And restrictive dyspnea means
Hatvet PHARMA introduces Hatcot MP, methylprednisolone 8 mg tablets, the ultimate power of glucocorticoids in more potent form. Methylprednisolone tablets, Hatcot MP tablets, glucocorticoid systemic drug. Indications: anti-inflammatory and immunosuppressive. Dosage for dogs: 0.5 mg to 1 mg per kg per day. For cats, 1 to 2 mg per kg per day. Route: oral. Presentation: 1 into 10 tablets. You can book your order online at www.hatvet.com. Looking forward to a long-lasting business association Thank you.
The difficulty in inspiration is due to some restriction. That means something is encircling the heart or lungs and preventing the inflation of the heart. Could be a pleural disease, severe pleurisy, or due to a painful pulmonary disease, or atelectasis, etc. So, if it is an inspirated dyspnea, it could be upper airway disease. If it is an expirated dyspnea, it could be a lower airway obstruction. Diagnostic tests. How we can diagnose all these things? Main diagnosis by clinical examination. Then you can go for blood analysis. Of course, in a severe pneumonia or asthma or pulmonary neoplastic conditions, you can go for blood tests like the CBC, ALT, AST, all these things can be done, especially the AST. Then imaging, thoracic ultrasound can be undertaken if you have it, X-rays, then CT, echocardiography, etc. Leave it. Then respiratory fluids can be taken and then analyzed for the type of cells found. Like the cells can be extracted from the bronchus. That method is known as the bronchoalveolar lavage. Don't use this technique because it is a very bitter technique. Otherwise, you can have directly puncture and aspirate by thoracocentesis. Then airway examination. That generally we cannot do. We should use a video bronchoscope, put it into the trachea and the bronchus and examine. I have used this when I was in the government district veterinary hospital where we had that endoscope, oral gastroscope. The gastroscope we introduced into the trachea of dogs. It was very beautiful inside. We introduced it inside and we went up to the tracheal bifurcation through the mediastinum. And while we are passing through, we can see that beating of the heart from outside. Okay, that is another thing. So that is video bronchoscopy, tracheobronchoscopy. Then we can use certain drug trials. Sometimes we see a bronchoconstriction. We feel a bronchoconstriction like a respiratory dyspnea, a musical wheeze. Both are there. As a drug trial, we give salbutamol or terbutaline or adrenaline. Then we observe. After 10 minutes, it is becoming okay. That means the bronchus become relaxed. The bronchioles became relaxed. So that our suspicion is right. That is a drug trial. In upper airway obstruction, upper airway examination is performed. Whenever the dog or the cat is presented in a very dangerous condition, it is struggling too hard for respiration, the tongue is blue, gum is cyanotic, immediately don't carry it for test everything. Don't carry it for the X-rays, don't carry it for immediately for bronchoalveolar lavage, thoracocentesis, etc. But what you have to do is, the first thing, make the patient stabilized. Whatever be the condition, make it stabilized. Give oxygenation. I have my own oxygen plant supply into all my rooms. Oxygenation is very, very the most important thing. Ventilate it or oxygenate it. Then after continuous oxygenation, the patient's mucous membrane will become pink, normal. At that time, you can pull out the tongue and do a laryngoscopy. You can examine the upper airway tract. or if you have, we can use bronchoscope. Sometimes to examine the larynx, we will have to sedate the animal with the respiratory distress, with the respiratory distress. So also, when we are manipulating the larynx, laryngeal spasms can occur. So to avoid all these things, even we can give a respiratory stimulant prior to it. The best recommended is doxapram, 0.5 to 1.5 milligram per kg IV first to stimulate the laryngeal motion, and then examining the larynx. And here also cervical and thoracic radiographs are useful for patients with laryngeal or tracheal disease to detect masses and collapse. Sometimes dog may be presented with upper airway tract obstructions, stridor like we say this as a dry honking cough. So typical to a tracheal collapse. To a good extent, we can detect it from a lateral thoracic radiograph, or it can be confirmed by a bronchoscope, video bronchoscope. Sometimes patients which are highly struggling, too much of struggling patients with the respiratory distress, we will have to sedate such patients. For sedating such patients, if you are giving silencing, immediately it will die, because they are potent respiratory depressants. So in such dogs, sedation can be achieved by butorphanol, acepromazine, or dexmedetomidine. See, I have written that butorphanol is a drug of choice in cats. Even in the dog, it is the best one. What I am using is butorphanol alone. Butorphanol can be used at a dose rate of 0.055 to 0.11 milligram per kg IM or subcut in such patients. You give a short subcut. That's what I am doing. Give butorphanol. It will give calmness to the animal. The patient will be very calm. And butorphanol I am using nowadays to deal with the kennel cough. Kennel cough, people are too much worried the dog is always coughing like anything. And here the best drug of choice is doxycycline, because a major portion is being done by this Bordetella bronchoseptica. So they are highly sensitive to doxycycline. So invariably the best choice of antibiotic is doxycycline. But along with that, the client will say that, sir, what about this cough, too much of cough? We give codeine. Nothing can happen sometimes. But give this butorphanol, the same dose, 0.055 milligram per kg subcut. By 1 or 2 days injection, it will stop coughing. It's an excellent antitussive, butorphanol. That is what I am using now. So, acepromazine has its own side effects like hypotension, etc. And now I am not using acepromazine, and dexmedetomidine has to control or sedate animals with a severe respiratory distress. Anyway, this dexmedetomidine should be used only when we have the reversing agent, that is antipamizole. Otherwise, better don't use dexmedetomidine. That was something related to the upper airway obstructions. Then diagnosis of lower airway obstructions need thoracic radiographs. This is classically associated with the bronchial or bronchointerstitial pattern on thoracic radiographs. See, number one is that I am not a good radiologist. And if I have a doubt, I used to convey the radiograph to our expert radiologists like Dr. Deepu, etc. So, but to a certain extent, I can also. So, a bronchial pattern, bronchointerstitial pattern, etc., can be seen on thoracic radiographs. Additionally, air trapping in cats with asthma may result in pulmonary hyperinflation and a flattened diaphragm. Then, if you suspect asthma in a cat which is coughing, even it is said that under sedation we can introduce saline into the bronchus, aspirate it, that is bronchoalveolar lavage. Then centrifuge it, take the sediments, it contains cells, smear it, and if it is having more than 17% eosinophils, it can be confirmed as asthma, feline asthma. Then the solid, the parenchymal diseases of the lungs. If you suspect a pulmonary edema, cardiogenic pulmonary edema, take the thoracic radiograph. So it could be a left-sided heart failure. Go for an ECG, thorough examination of the cardiovascular system. If needed, you can go for echocardiography. At least if you don't have an echocardiograph, thoroughly examine the cardiovascular system, the pulse, auscultation of the heart, etc. Then take an ECG. ECG is so simple. Interpret the ECG. To a certain extent, we will come to know that it is a left-sided heart failure. So, when the etiology becomes unclear, other diagnostic procedures can be used, such as we said, a bronchoalveolar lavage can be done. If everything fails, we can go for, if we have thoracic CT or lung biopsy, at least lung biopsy we can do through the intercostal space. If it is a single solitary lung mass, even that part can be opened and a small area can be excised from the lung, and it can be subjected for histopathology. And if it is having pleural space disease, thoracic imaging or X-rays is the mainstay of diagnosis. So in pleural space disease means mainly if there is pleural effusion. In pleural effusion, if you take a radiograph, it will be well clear. Even before that, auscultate it. If there is no lung sound, it is highly suspicious of pleurisy or pleural effusion. And if you suspect a pleural effusion, immediately take a radiograph. In pleural effusion, if there is fluid in the pleural effusion, in the lateral chest radiograph, the anterior lower areas will be completely opaque. Okay, that is a pleural effusion. So, because that's when the animal is standing, by gravity it will come down and you can see the fluid in the lower areas. So, as when you see this, immediately puncture the pleural space and aspirate, it will get the fluid. Immediately while taking the fluid, subject it for concentration by centrifugation and then try to identify the cells. Sometimes the pleural space disease can be due to a neoplastic condition. Then flail chest. It is a surgical emergency. It's a typical case where there is multiple fracture of more than 2 ribs, segment of more than 2 ribs. And so what will happen? That area we can see depressed, like a pit. May not be having trauma outside, but the trauma is inside, or the chest wall is completely disturbed and fractured. So there is a pit there. when the animal is inspiring, the chest wall will inflate and this area of trauma will be deflated. And when during expiration, the chest wall will be deflated and this area will be coming bulging out as inflation. So the opposite paradoxical changes occur. This is known as a flail chest. This is an emergency, it's a surgical emergency. Rib fractures are extremely painful. We will come to know about certain medicines which can be used as bronchodilators. Beta agonists can be used such as epinephrine against bronchoconstriction or bronchospasms. As bronchodilators, this can be used. Beta agonists such as epinephrine, 0.1 milligram per kg in the cat or 20 microgram per kg IM or IV or subcut, or 0.1 ml per kg of 0.001% solution subcut. Ephedrine can be used orally 2 to 5 milligram in the cat as intramuscular orally. Isoproterenol can be used 0.44 milligram per kg every 6 to 12 hours orally. 0.1 to 0.2 milligram every 6 hours IM subcut or IV, or as aerosol, isoproterenol. So epinephrine is the best, what I have seen. Metoprolol can be used 0.5 milligram per kg every 6 hours or as aerosol. Albuterol 200 microgram every 8 hours as aerosol or 50 microgram per kg orally. Terbutaline can be used. Isoethyrene can be used. All these doses we can write it on our, we can paste it on our in our operation theatre, because these are all essential things which we need not keep it inside our mind, because we are not regularly using these drugs. We will forget all these things. I will give you the PowerPoint so that you can take all these doses and make a chart and you can paste it inside your operation theatre. Okay. Anticholinergic drugs or vagolytic drugs can be used. Atropine or glycopyrrolate can be used as bronchodilators. Methyl sandines can be used. This is another drug which is very, very commonly used. Aminophylline injection, which contains theophylline. Our aminophylline injection. Our deriphyllin ampule contains this dose is 10 milligram per kg in the dog, 5 to 6 milligram per kg in the cat. Can be given as IV infusion, or theophylline base, or oxytryphyllin, or slow release theophylline anhydrous. All this can be used. These are methyl sandines. Then the commonly used glucocorticoids. Prednisolone can be used at 1 to 2 milligram per kg. Prednisolone, sodium succinate can be used. Dexamethasone is long acting. 12 to 24 hours it can act. Dexamethasone and betamethasone and beclomethasone, etc. are synthetic glucocorticoids. Dexamethasone at 0.2 to 2.2 milligram per kg. Triamcinolone 0.25 to 0.5 milligram per kg. Beclomethasone 200 microgram every 6 to 8 hours. Then other antihistamines such as montelukast and zevirlukast can be used. Cyproheptadine available as 4 milligram tablets can be used. Then antihistamines such as chlorpheniramine maleate, the very commonly used Avil, Chlorelvet, Zeet, 0.22 milligram per kg, 2 to 4 milligram per kg total dose. Then diphenhydramine hydrochloride can be used. Dimenhydrinate can be used. And the commonly used hydroxyzine also can be used as an antihistaminic. Against cough, we can go for codeine, we can go for hydrocodone. Codeine is not available as such nowadays because it can be abused. Codeine, hydrocodone, burst is butorphanol. I have said that. If the dog is coughing all the time, don't go for codeine, etc., hydrocodone, etc., but burst is butorphanol. 0.55, 0.055 to 1.11 milligram per kg subcut. Then dextromethorphan, morphine, it is not available to us. Then decongestants, if there is severe rhinitis, if it is having a mouth breathing, we can go for a pseudoephedrine. Oxymetazoline in nasal sprays also can be used, especially in the pup with the rhinitis. Also ketones, it can be used very well. So with this, I am concluding the session of these were the basics. These were the basic things which we were discussing about. And now, Bharat Mata ki Jai.